So first we're going to talk about why to temporize, when not to temporize. I know we talked a lot about designing these temps, but you really have to take into consideration the patients you're working on, because not everybody is the best candidate for giving a immediately loaded implant-supported tooth to. Some patients, like we talked about earlier, they have a deep bite. If they have really extensive protrusive lateral movements, if they have a lot of crowding, a tooth is in the way, if they're a smoker, diabetic, if you just did, an immediate implant with a lot of bone remodeling, you probably don't want to load that implant the same day, even though you have a really good insertion torque. For example, you're placing an implant, you can have 3 threads in bone at the apex of your socket. You'll be at a 45 NCM insertion value. You'll be like, yeah, let's temporize it. I like to call that a false stability, because sometimes that bone, especially with the curve of integration over time, you're going to lose that apical stability during the 4-week mark, and that can lead to failures. So the temporaries we design, I know we've gone through how to create it in Blue Sky. They can be really nice looking. So after importing into the mesh mixer, we can glaze them. We can put a little, analog on there. So some patients, one of the downsides of temporizing a tooth, it's a fire temporary, right? It's lit on fire. That's the joke here.
Really lit that on fire.
I did, yeah. So one downside of temporizing is patients sometimes don't want the final crown, because then they're like, why am I coming back and paying $4,000 extra for something that's going to look the same? I like this one already, so what's the point? So careful with making them look too nice. All right, so here's a little workflow of surgery. So we lay a little conservative flap. We talked about the palatal approach, how we tuck the tissue buccal, and we deliver this implant-supported temporary the same day. This surgery here, right now, I would say we block out, half an hour for the surgery? So we have the guides. We know exactly where the flap is going to be. It's an anterior tooth. We have a pre-printed temporary. After we snap the guide on, placing the implant is 15 minutes, putting the temp on and adjusting occlusion, I would say it's a 5-minute process. So it really cuts down your surgical steps. And that's the case when we restore it. So I'll show you guys how to scan that emergence after the patient has been wearing the temporary for, this one is one of the cases where it was an indefinite amount of time. This patient was wearing this tooth, I would say, for around a year until I convinced her to transition to final. I'm like, it looks really white, it looks really bad, we should make you a final one. Let's do it. So that's the final restoration. We scanned it for her and she's pretty happy with it. And we can see how the fake papilla can actually represent real papilla pretty well. That's the one benefit of shaping the tissue at time of surgery. Or at time of uncovery. Okay, so here's another example. Previously we discussed the anterior temporization. I've showed this case to a few of you, chairside, but this is for a molar. One difference here is that we don't want this to be at all even close to occlusion. So when I put this custom, I call it an anatomic profile generator in, I shave it to the top of the tie base without touching the tie base and make it flush with the tissue. So that prevents food from getting in there, and it prevents them from touching it or eating food with it. They're not going to be chomping on chicken wings with the flat area, because most of the time it resembles their gum. And I know Matt has actually printed it from Denka gingival base, the pink one, or was it surgical guide one? Both. Oh, cool. So he's done it with both. Yeah, then it looks like the ridge. So.
And model resin too.
And model resin. Now, I know that we can leave it, we can suture that technically. I like to trim the top here, semilunar incision, just so I can get really nice closure and reapproximate the tissue as well. I'm a firm believer in, at least for single units, approximating things so things don't get in there.